So good morning everyone. So we've learned the theory by Faraz. So one night before exam, what do? We just revise it quickly. So we've made our notes. Let's revise the notes. So the right combination. My agenda will flow like this. So to begin with some case studies, like we have here a gentleman with HbA1c at diagnosis around 9.6. Another gentleman less than 50. Again the diagnostic HbA1c 9.2. So what's the difference between perception and practice? We believe that mostly the diabetes comes to notice early. And what do we define early diabetes? Maybe somewhere between 6.5 and 7 we'll diagnose, we'll catch the patient. But that is only the perception. The practice is most of the diabetes gets to notice only after the HbA1c is above 7.5. So the diagnostic HbA1c in clinical practice is somewhere between 7.5 and 9. And when we talk of specifically one word is there, why the topic included the word Indian? Because the Indian phenotype is still different. We actually have increasing prevalence. We also have increasing prevalence of young onset diabetes. We have a very high carb intake. All 3 meals are high carb meals. Then we have a lesser pancreatic beta cell mass because we have more of visceral adiposity. So we have decreased insulin secretory function relative to insulin resistance. We have less insulin in our systems and we have increasing visceral obesity. So this is the Asian phenotype. Now as we already discussed and we have known this fact of metabolic memory, the bed legacy effect. So we want to hit early and hit hard. So what is the FDC? We have already seen, and let's look why we are looking for FDCs. So let's for a minute forget the F. Just forget all F words, right? Just focus on the drug combinations. So this is diabetes, hyperglycemia and the octate, the defronzose, the famous defronzose octate. So you have hyperglycemia, you just add one molecule and you find that you will be targeting 1 out of the 8 pathophysiologies. You add sulfonylurea, you will be targeting 2 out of 8. You add a thiazolidinedione, you will be targeting 4 out of 8. You again choose DPP4, again you will be targeting some 4 out of 8. GLP-1 RA will help you target 6 out of 8. But still you will never be able to target all 8 pathophysiological defects. So there are certain good combinations like we just talked, metformin with exenatide and pioglitazone. So we are targeting 7 out of 8. The kidney still remains. You have forgotten the kidney. So to cover kidney you add EMPA, okay? No, you have added a DAPA, okay? Any of the SGLT2I. But then again, now you leave out the adipose tissue. So what do? Here you have EMPA-LINA-MET and you have left out so many things. Just 5 out of 8 you are covering. So any drug combination that gives you 8 out of 8, yes, you can do that also. Now you have twin cretins. So you use a twin cretin with thiazolidinedione and SGLT2I and you will cover all 8 of the pathophysiological defects. But what will you do? You will be giving this to your patient, a plate full of medicines. Pills, pills and more pills. The pill burden, this is what we are discussing. And this will be the status of your patient. Everyday dilemma. कौन सी खानी है, कितनी खानी है, सुबह ये वाली 2 गोली, एक लाल रंग की गोली, एक पीले रंग की गोली, एक छोटी गोली, एक मोटी गोली. So lost. So let's bring our F back and go to the fixed drug combinations. But when you go to FDCs or fixed drug combinations, yes, you simplify life. From pill burden, you come down to one single pill. But as Faraz has already discussed in a different format, that FDCs, you can't just have FDCs for everything. There has to be a rationale for FDCs. You can't put the drugs together. If they are having same mechanism of action, the same group, like they are coming both from the secretagogue or the sulfonylurea groups, you can't combine them. If the 2 drugs have different pharmacokinetics, for example, the dual cretin terzepatide, it is once a week. You can't combine terzepatide with a molecule like sulfonylurea because it has to be given with every meal or maybe once a day. So the pharmacokinetics also has to match. Then the combinations can't be supra-additive, like you can't give insulin with sulfonylurea, otherwise there will be severe hypoglycemias. So the combination has to be recommended by the guidelines. So you can't have all the FDCs. Again, the pros and cons we have discussed in a different format, like yes, the pros will be, it will decrease your pill burden, it will increase your compliance, adherence, it will decrease your cost. At times cost might increase, but mostly decreases. It will decrease your medication errors कि सुबह 3 खानी थी शाम को 5 खानी थी, या पता नहीं सुबह 5 खानी थी शाम को 3 खानी थी, I don't know. So synergistic action will be increased. Similarly, there will be some cons, like the dosage flexibility is lost, as we discussed. It will need to discontinue if the patient is allergic to even one component of the molecule, like may not be allergic, like we have to drop metformin if the kidney starts misbehaving. So we have the cons and the pros of FDCs, but let's keep the life simple and follow the simple approach, that is initial combination therapy. It will target your multiple pathophysiological defects. So the top 3 drug combinations or FDCs which we have been using since quite some time is metformin, glimepiride and pioglitazone. At times we replace pios with the voglibons. Then we have the non-hypoglycemic FDCs like the empamet-lina combination. Then you have the latest combination which my chairpersons were mentioning. Now we have DPP-4 put into the basket in that capsule of metformin and glimepiride. So this is the latest 3 drug FDC. So what are the guidelines recommending? The guidelines are recommending that yes, you can start with 3 OHAs when the HbA1c, the starting HbA1c is above 9. So if it is above 9, you can think of starting triple drug FDC or triple drugs individually also. And Indian guidelines also state that if the HbA1c is 1.5% above the target, you can start with a triple drug. Indian data, there are people who start triple drugs even when the HbA1c is less than 8, but most commonly it is preferred between the HbA1c of entry point 9 to 9.4. This is the Indian data. Again a repetition, what is the guideline, the guiding force to decide which will be your second and third glucose lowering drug based on the ABCD approach? Age, body weight, complications and duration of diabetes. Banned drugs, as my chairperson just mentioned, there is a bundle of banned drugs. So these drugs are in the market still, but in different combinations. So there are particular strengths which are banned, like gliclazide metformin is still in the market, but with the rationalized drug strength. So FDC, what is FDC? What is FDC? Fixed drug combination, fixed dose combination. No. FDC is the final dictum commemorate, and the final dictum commemorate is the Indian average HbA1c at diagnosis is more than 9.5, and the time to control it, you have the whole lifetime. Please control it if you can. Why we are not able to do it? Because the inertia lies at 360 degrees. The problems are pill burden, pocket burden, complicated regimes, reluctance to give up their behaviors, fear of multiple drugs and their side effects. All this is much heavier than the fear of the disease and its complications. Patients don't fear diabetes. Patients don't fear its complications. Patients fear many more things. So the combination therapy strategically improves a single drug efficacy by more than 80%. And FDCs answer most of these sought after queries, like they will decrease your pill burden, pocket burden, simplify the regime, increase adherence, increase efficacy, and they will target multiple pathophysiologies. But remember that multi-step approach is only needed after rationalization. So we have an authority, the government regulatory bodies, to approve any FDC. We can't move without that. So this is your capsule. It has got multiple drugs, and for today it has got a thank you so much.